algorithm for you to employ in your clinical areas. So what is lymphocytosis basically? So it's a count of over 4,000, absolute lymphocyte count of over 4,000 per microliter in adults, over 7,000 in older children, and in infants it's more than 9,000. So as I already said, I'll not be overstating that a good clinical history and physical is 50% of the diagnosis. So for any clinical workup, this is the most important uh, initial part you should do. And in cases of lymphocytosis, you can couple it with the first tool, which is the morphology. And uh, with this scenario, you have different approaches and different difficulty levels. You have a very simplified case of 2 + 2, 4, to cases where you will scratch your head, to cases where you really clench your fists. So to give you an example, for example, this is an 8-year-old kid with fever, sore throat, and lymphadenopathy. And on the right, you are seeing a atypical lymphocytes, large lymphocytes with steel blue cytoplasm, open nuclei, which is a characteristic downy cell, which you see in EBV infection. So this is infectious mononucleosis. It's a straightforward case. And again, you may have seen a lot of these small lymphocytes with high NC ratio, and in the background you do have smudge cell, another walkaway in a 57-year-old male with fatigue, fever, and weight loss. And similarly, as I already mentioned, 60-year-old male, pancytopenia, splenomegaly, this is half of your diagnosis. You can diagnose hairy cell leukemia just on the basis of clinical history, 50%. And when you see these medium-sized cells with shaggy borders and hairy projections, you tend to have good diagnosis. And similarly, an 8-year-old patient with abdominal mass, fever, weight loss, and you see these, again, medium-sized cell with relatively open chromatin, lots of cytoplasmic vacuoles, and you tend to get to the diagnosis of Burkitt's-like morphology. Now we come to the area where you really want to scratch your head. So these are the highly atypical lymphocyte. You can see this high NC ratio, and they're very cleaved, angulated with irregular nuclear outline. And you must be wondering whether this is a reactive lymphocytes or a neoplastic one. By the way, this is a case of a kid with a nagging cough and had pertussis. So this is a case of pertussis where you can see these highly atypical lymphocytes. Again, very similar cells, highly cleaved nuclei, high NC ratio, and you must be wondering another phase of pertussis. By the way, this is a 60-year-old with the diagnosis of mantle cell lymphoma. So they may have similar morphology, and that's what I mean when you scratch your head or you clench your fist while looking at the different flavors of morphologies. So you may have seen in your routine practice this cell, which is a large granular lymphocyte, and again, depending upon the clinical scenario, these could be normal LGLs or may be part of a neoplastic process such as LGL leukemia. By the way, this is likely a case of post-splenectomy. It's a benign LGL. And this case, the similar large cells with lots of granules, and whether it's reactive or neoplastic, this was a case from a LGL leukemia. So again, similar morphologies, but different disease processes. And everything which glitters is not gold. So every cytoplasmic vacuolation is not Burkitt's. So you may see it in lymphoblastic lymphoma. You may see in some reactive lymphocytes. Again, very atypical morphology, a lot of convolution in these lymphocytes, and almost giving you appearance of a flower cells. And these are, by the way, called flower cells. And they are characteristically present in adult T-cell lymphoma leukemia. Is it is it unique to ATCL? The answer is no. You may see in T lymphoblastic lymphoma, other type of leukemias. You may see in blastic variants of mantle cell lymphoma. So you can see these kind of flower cells. So how to deal with this dilemma of reactive versus new plastics? So what next tool you have to answer this question of reactive versus new plastic? So the answer is flow cytometry. So basically, flow cytometry is the easiest way to prove clonality in B and T cell lymphoproliferative processes. In B cells, you can do kappa lambda light chain evaluation for restriction of either kappa or lambda light chain. In T cell, you similarly can do it with T cell receptor evaluation, and you can couple it with pan T cell expression, and you can look at the variable intensity and loss or gain of different T cell antigens. So this is a case of reactive B lymphocytes, and these are the lymphocyte gate. And on the right side, you have these CD19 positive B cells, and this population is expressing both lambda as well as kappa. So this is a typical reactive polyclonal population of B cells. Similarly, this is a again, lymphocytes are gated, and these are these T cells, and there are variable T cells, and all of these pan T cells, for example, CD5, cytoplasmic CD3, CD2, CD7, they're all expressing same intensity of expression of these antigens. There is no loss, and there is no dimness or heightened expression in these lymphocytic populations. So these are reactive T lymphocyte. In contrast, you may have a T cell population, for example, over here, which does not show CD8, which means there is a loss of CD8. Similarly, there is a loss of CD7, and the CD2 is expressing in few tumor cells, while CD4 and CD5 are expressed in good intensity. So this is a case of new plastic T cells. So you have this tool to basically address this question of whether the given lymphocytosis is reactive versus new plastic. So coming to the, again, back to the clinical, physical, and morphology, which is the gateway to your differentials. And once you decide whether the lymphocytosis is reactive or clonal, among reactive lymphocytosis, you have a long list of differentials. Mostly these are due to infections, and viral being at the top of them. And you can see EBV related CMV, HIV, measles, mumps, and other viruses. Bacterial infection generally do not cause lymphocytosis. But there are certain bacterial infections such as pertussis, brucella, cat scratch disease. They are associated with lymphocytosis. Among parasites, you have toxoplasmosis and malaria. In our part of the world, tuberculosis is very common, so that also is associated with lymphocytosis. The non-infectious causes, you may have thyroid disease, Addison's disease, inflammatory bowel disease, different vasculitides. They may show lymphocytosis. Certain drugs in a hypersensitivity reaction may cause lymphocytosis. And as I already mentioned, post-splenectomy, you have lymphocytosis, and majority of those lymphocytes are LGLs, and they may persist for years to come. Then you have persistent polyclonal B-cell lymphocytosis, typically in a smoker female patient, which is a benign disorder. So once you have constructed the differential diagnosis with good clinical history, and you do certain serological testing for different infectious diseases, then for thyroid testing, Addison disease testing, you can come up with a particular or specific diagnosis. So the question is when to go for flow cytometry. Is there a criteria? So I've laid down these 5 criteria which help me a lot to decide whether the current lymphocyte should go for flow cytometry or not. When you see abnormal cell in peripheral blood which are not going either to south or north, you can order flow cytometry. When malignant etiology is clinically suspected, or you see cells which do not match with clinical history. For example, you have a typical clinical case with a suspicion of, say, infectious mononucleosis, but you see malignant looking cells in the peripheral blood. So you can order cytometry to look into it, whether it's a reactive condition or a malignant condition. If the lymphocyte persists for more than 3 weeks, or older patient with count over 6,000. So that prompts you to go for flow cytometry. So what you do in cases of lymphoid malignancies. So you can easily diagnose in most of the cases the B cell lymphomas and the T cell lymphomas. Among B cell lymphomas, there are different B cell markers which are highlighted on the top, the CD20, 19, 79A, and CD22. And I've categorized the B cell lymphoma under 3 categories. There is another way of doing it, which I'll briefly mention at the conclusion of my talk. So the B cell lymphomas, I divide basically for purpose of understanding into 3 types: the CD5 positive lymphomas, CD10 positive lymphomas, and CD5 negative, CD10 negative lymphomas, so dual negative lymphomas. Remember that B cell lymphoma means they express most of these pan B cell markers. The T cell lymphomas, they express the pan T cell marker, and their expression is variable. And the pan T cell marker, they include CD3, 2, 4, 5, 8, 7, and CD1, etc., etc. So among CD5 positive lymphomas, you have 2. One is the CLLSL, and you can include MBLs in the definition, under the definition of SLL-CLL, because majority of your MBLs, they have the similar phenotype of SLL-CLL. And then you have mantle cell lymphoma. So these are the 2 common CD5 positive lymphomas which you encounter. The CLL-SLL has small cells, round nuclei, and generally they have smudge cell in the background. And by phenotype, they do show CD5 positivity. The CD20 is characteristically show dim expression, and so is the light chain. CD23 is positive. CD10 and FMC7 is negative, and cyclin D1 is negative. And these cyclin D1 and CD23 tends to differentiate it from its other CD5 positive lymphoma, that is mantle cell lymphoma. So this is the CLL case, and you see that the tumor cells, they show CD22 positivity. How can I use my cursor? All right, so these are CD20 positive, CD23 positive. CD20 has a dim expression. FMC7 is characteristically negative. I'm missing one slide. That's fine.
Sir, you can use your cursor.
Yes.
You can use the cursor of your laptop.
Okay. All right. All right. So again, you can see, so this is a B cell phenotype. This is CD22 expression. CD22 is dimly expressed. FMC7 is negative in these cells. Again, CD19, which is a B cell marker, is expressed, and they are expressing CD23. One slide is missing where I showed that these are CD5 positive and CD10 negative. I think the slide is not here. MBLs is a distinct entity in the current 2016 update. So it is a monoclonal, by definition, it is a monoclonal B cell in peripheral blood of less than 5,000 per microliter with absent extramedullary disease, even if cytopenia or disease-related symptoms are present. And majority of these cases of MBLs have a phenotype of CLL, but remember, non-CLL phenotypes are also seen. Generally a benign condition, but most MBL is considered a precursor lesion in virtually all cases of CLL and SLL. The mantle cell lymphoma has generally small cell, uniform size. The nuclei are irregular, and sometimes they are so irregular that they may take the shape of flower cells. Again, CD5 positive. In contrast to CLL, they are bright CD20 positive, bright light chain restricted. Again, cyclin D1 positive, FMC7 positive, another contrasting feature with CLL, SLL. CD10 negative and CD23 negative. So this is mantle cell lymphoma, CD19 positive, lambda line chain restricted, kappa is negative, CD5 positive, CD20 strongly positive, uh, FMC7 positive, again CD20 strongly positive. CD10 lymphomas, you have follicular lymphoma, which is CD10 positive, apart from the regular B cell markers. They are BCL2 positive, CD23, CD5, and cyclin D1 negative. So this is the case of follicular lymphoma, where you have CD19 positive cell which do not express CD5, do not express CD23. However, these CD19 positive express CD10 with lambda light chain restrictions. It's the case of follicular lymphoma. Another CD10 positive lymphoma is Burkitt's. Again, small to medium sized cells, conspicuous nuclei, and vacuolated cytoplasm. CD10 is strongly positive, strongly CD20 positive, light chain restriction. And if you have bone marrow fine, you can do Ki-67, it will show 100% nuclear staining. In contrast to B lymphoblastic lymphoma, they are TDT negative and CD34 negative. So this is how the clinical history, the morphology, and the phenotype favors or makes a diagnosis more clear. Again, pre-B-ALL, as I mentioned, in contrast to Burkitt's lymphoma, the pre-Bs are TDT positive and CD34 positive. And generally, in contrast to Burkitt lymphoma, CD20 is either negative or very dimly expressed. CD5, CD10 negative lymphomas. So we have lymphoplasmatic plasmacytic lymphoma, which have a nuclear shape of a plasma cell, but the nuclei of a lymphocyte. So it does not have any specific marker, and the accompanied plasma cells and some of these tumor cells may show plasmacytic expression. Hairy cell leukemia has a characteristic phenotype. They are CD11C positive, CD25 positive, CD103 positive, and annexin A1 positive. So there's a case of hairy cell leukemia. Again, lambda light chain restricted, CD20 positive, CD5 negative, CD10 negative, FMC7 strongly positive, and these are CD11C positive, CD103 positive. So this is a case of hairy cell leukemia. So that concludes the B cell lymphomas, and among T cell lymphoma, there are a long list of T cell lymphoma, but I've just mentioned few which you encounter in your clinical practice, and these include T cell prolymphocytic leukemia, T cell large granular cell leukemia, and then adult T cell lymphoma leukemia, mycosis fungoides, Sézary syndrome complex, and then T lymphoblastic lymphoma / leukemia. I'll give a couple of examples. So this is a T cell PLL. Again, lymphocytes are gated, CD8 negative. However, CD4 is positive, strongly positive in these cells. These are the CD3 cells. And this is a alpha beta gamma receptor positive, and gamma delta is negative. So this is a case of T cell PLL. Few other CD5 positive. And this is the PT-ALL, and you see I've mentioned that the Frall cell may be seen in T cell lymphoblastic leukemia as well. So again, they have characteristic phenotype of cytoplasmic CD3 positive, surface CD3 negative, and they may have variable expression of different T cell markers. So they should, and they do express CD3 34, and CD and TDT. So this is a case of pre-T cell ALL. So far we have discussed various differential diagnoses and a sequential approach, and I promise that I will give you a sort of algorithm at the end, and this is the algorithm I was talking about. So you have a case of lymphocytosis, so you get a complete history and a physical examination, and I did emphasize over the importance of these detailed clinical history and its relevance to the differential diagnosis and a proper diagnosis. So the next is you see the cell under microscope, and then you order flow cytometry. Flow cytometry will bifurcate it to either clonal lymphocytosis or a reactive lymphocytosis. Among the reactive lymphocytosis, you raise a differential diagnosis of viral infection, bacterial, protozoal, autoimmune infections, drugs, etc., etc. And with the help of good clinical history and relevant testing, specific testing, you come up with a diagnosis. And this diagnosis is managed accordingly. So by the way, majority of these lymphocytosis in reactive conditions are due to these underlying condition. If you take care of these underlying condition, the lymphocytosis generally goes away. So among the left side, the clonal lymphocytosis, you have T-cell lymphoproliferative disorder or T-cell lymphomas, and you have LGLs, mycosis fungoides, PLL, adult T-cell lymphoma, leukemia, etc., etc. Among B-cell, you have the B-cell lymphoma. So I've done a different algorithm here for your understanding as well. So either you separate it on the basis of CD5 positive, CD10 positive, and CD5, CD10 negative lymphoma, or you may have a CLL phenotype and non-CLL phenotype. So among CLL phenotype, you have CLL when the absolute count is equal to or greater than 5,000, and monoclonal B-cell lymphocytes when the count is less than 5. The non-CLL phenotype, you have you have to make diagnosis of these lymphomas, which we have discussed: follicular, mental, hairy cell, LPLs, marginal zone, Burkitt's, etc., etc. So once you diagnosed these lymphomas, the next logical step is basically the staging, and where you may end up getting bone marrow biopsy, CT or PET-CT, etc. And once the staging is accomplished or done, the patient is ready to receive specific chemotherapy. Thank you very much. Hello. Yes, Marine, I'm done.
Yes, thank you very much, sir.
Okay, all right.
The problems of connections are everywhere. Okay. So I'm sorry for a bit interruption in my voice. Thank you very much, sir, for giving us wiser about approach to a patient of lymphocytosis. We really enjoyed the talk, and there are more than 70 participants, the residents of hematology and residents of oncology, residents of medical oncology, and residents of radiation oncology. Everybody has enjoyed the talk, and we'll be having question and answers in the end. Thank you very much, sir, for joining us. Right. So we go to our next talk. We are really honored to have Dr. Toby and Professor Leslie on board. So our second speaker would be Dr. Toby EYRE from Oxford University Hospital, Oxford, United Kingdom. Thank you very much, Toby, for being here. So he'll be educating us for the prognostic markers and new advances in the management of CLL and low-grade lymphoproliferative disorders. Thank you very much, Toby, for spending time out on Saturday. Thank you very much. Over to Dr. Toby EYRE. I hope you can share your slides.
Can you see them?
Yes, I can definitely see beautiful Cambridge.
That's a good start. You can see my slides. Yeah. And you can hear me okay?
Yes.
Okay, great. Well, thank you for the invitation to speak today, and your presentations and everything seem excellent, as does your program today. So I hope you enjoy the event. Thank you for the invitation. I'm a consultant hematologist in Oxford, in the UK. You can see my details there. And for those of you who like Twitter and medical Twitter, that's my Twitter handle, if any of you are interested, from there. So I'm going to speak a bit about first-line treatment of follicular lymphoma and CLL in 2020. Please do be aware that obviously I want to provide you with a kind of very up-to-date talk, including new treatments. Now, I appreciate some of these may not be widely available at present, but hopefully it's reasonable to include these for kind of educational purposes and perhaps a kind of view on what is to come. Here are some conflicts of interest for me. So I want to start with a case because I think it's always interesting to kind of talk around a case. This is a 57-year-old builder, one of my patients recently, hypertension, but otherwise well, not a smoker, drinks a small amount of alcohol per week, lives in the UK with his wife and 2 children, has some blood pressure medication, but is otherwise fit and well, but presents with abdominal pain to his GP, some weight loss and a neck clump. Goes on to have a CT scan and has widespread lymphadenopathy, cervical, mediastinal, retroperitoneal, pelvic and inguinal, an enlarged spleen at 16 centimeters and a large retroperitoneal abdominal mass of 9 by 7 centimeters. You can see his blood test there, mildly thrombocytopenic, anemic, with a normal LDH. And he goes on to have a cervical lymph node biopsy and showing characteristic features of follicular lymphoma. So CD10 positive, BCL2 positive infiltration within the lymph nodes in a follicular pattern. Importantly, negative for cyclin D1 and CD5. We've just heard a talk also explaining the diagnostic parameters around mantle cell lymphoma, but in a biopsy, certainly you want to look for CD5 and cyclin D1 in these cases. And there was no evidence of high-grade transformation. So this gentleman's got an ECOG of 0. He's still working, but he's clearly struggling with fatigue and has quite a bulk of disease. So I've calculated his Flippy score there for you. And what you can see is his Flippy score is 3. So I suppose a kind of key question here is treatment options. I think it would be clear to say that he wouldn't be somebody I would want to observe for particularly long because of the fact he's got symptomatic disease and it's bulky. So just as a way of background on follicular lymphoma and some of the prognostic indices, there are a series of them. There are quite a lot in the literature, increasingly confusing, I have to say, in some regards. So I'm just going to walk you through 1 or 2 of them just to give you a feel for them. Follicular lymphoma is the 2nd most common non-Hodgkin lymphoma. Median age is 62, so about a decade younger than CLL. It's characterized by the 14-18 translocation, but that's by no means the only aspect of this pathophysiology. Actually, you can test individuals, kind of healthy people walking in the street, and you'll find the 14-18 translocation in a small proportion of otherwise healthy people, which is interesting. And of course, they don't all go on to develop follicular lymphoma. So the biology of the disease is much more complicated, and the role of the microenvironment is very important here. As you'll be aware, there's a risk of high-grade transformation, and you'll also be aware that the disease course is heterogeneous. About 20% of people on active observation never require treatment at a 10-year follow-up, which is very interesting. But of course, you've got another 20% who relapse early and have a really quite poor prognosis, and we'll talk a bit more about them. But if you take the population as a whole, the median overall survival somewhere between 15 to 20 years with modern therapy. And on average, most frontline therapies give you a 3-year PFS of around about 75%. I'm going to talk you through some risk stratification tools. They're of course all, imperfect in their own way, but obviously they have their pros and cons. And you can see there, here's the Flippy score. So basic baseline clinical parameters that you can use to help prognosticate. It has some value in that you can clearly divide patients out. What I would say is that clearly what you can see is that actually, although some patients are deemed to be high risk by a Flippy score of 3 and above, what you can actually see is that even within the high risk group, 40% of people are alive at 10 years. So there is a large minority of those patients who actually still do very well. And if you think about somebody who's, say, 65 with small volume disease in multiple sites, so widespread lymphadenopathy, actually that's a score of 3, and they may not be biologically particularly bad players. So I think you know, it's an imperfect scoring system, but certainly worth considering measuring in your patients. What about the Flippy 2 score? The Flippy 1 score was in the pre-rituximab era. The Flippy 2 score is slightly different, but similar in many regards. So a number of similar parameters there. The number of nodal sites is changed to nodal diameter. So this is really looking at bulk disease rather than the number of nodal sites. And the LDH is changed to beta-2 microglobulin as a kind of marker of disease bulk, and stage is switched to bone marrow involvement. So it's similar but slightly different, and really gives very similar results. What you can see here is, again, the high risk group, still a proportion of those, you know, 30 to 40% still doing very well at the kind of long-term follow-up, but this perhaps distinguishes slightly better the groups. In terms of kind of modern techniques and tools that are available, a PET CT scan has been able to help differentiate patients. So this is a pooled analysis of different prospective clinical trials looking at the total tumor metabolic volume. And what this shows is that if you divide patients by high and low tumor volume, you can not only distinguish according to progression-free survival, but also indeed overall survival, which is interesting and relevant. So those basically with a high burden of disease at baseline have a shorter progression-free and overall survival. And indeed, this was prognostic on multivariate analysis. So that's a little bit about clinical features and radiological features. What about biological features? Well, there have been a number of series looking at varying parameters here. This is an example. This is something called the Flippy M7, where a number of genetic features and clinical features are divided up to provide a scoring system. And you can see there in figure A, there are clinical features, so Flippy score and ECOG, that provide a weighted scoring system, but then a series of biological parameters, genetic mutations, some that are very important in the disease, including CREB-BP1, EZH2 is important as well. They provide a weighting scoring system, and you can see here that this can prognosticate quite nicely in both the training and validation cohort. I suppose importantly here, what you're starting to do is you're starting to pull off a group of patients who are at particularly high risk of disease progression, etc. And so, you know, in time, people may be able to use scoring systems such as this to maybe intervene differently in that group of patients. So that's a bit on prognostication. There's much more really to talk about there, but that's just a brief overview. What about frontline therapy? I wanted to update you on the PRIMA study because this has been, the follow-up of this has been published recently, the 10-year follow-up. Just a reminder, this is the study that really established rituximab both in induction and as maintenance treatment in frontline follicular lymphoma. Patients with high tumor burden were treated with the investigator choice chemotherapy, either CVP, CHOP, or FCM. Patients who responded according to CT criteria were then randomized to maintenance or observation. This is the long-term follow-up. What you can see here is that those that received maintenance, the median time to next treatment wasn't reached at 10 years. So if you give somebody R chemo and then R maintenance and they respond, that group of patients on average still don't need treatment at 10 years. If you don't give maintenance treatment, the median PFS is 6.6 years, so still substantial, but obviously there is a difference there. But the overall survival at 10 years is still not different. So there are pros and cons, of course, of maintenance rituximab, as you'll be aware: increased risk of infection-related toxicity, cost implications, delivery implications on the treatment units, and also the fact that survival has never been shown to benefit those who have rituximab maintenance. So pros and cons of the two, of course. That study then led on to the gallium study, which is a more recent study that's been published and presented. This is again taking patients with follicular lymphoma who are untreated, requiring therapy. And this time they were randomized to either obinutuzumab or rituximab. So taking the kind of standard, what we call the kind of, I suppose, the arm that won in the PRIMA study, the rituximab and then rituximab maintenance arm, and randomized patients between that therapy and then a novel glycoengineered type 2 monoclonal antibody. What you can see here is that there's no observation arm, of course, in this study. So the assumption with this trial is that there is benefit to maintenance, which of course is still up for debate. Response rates and CR rates very similar across the two arms. So the initial induction therapy similar in terms of kind of CT measured response. But what you can see here is a considerable progression-free survival advantage to using obinutuzumab as the antibody backbone. So the 3-year PFS difference between 73% with R chemo and 80% with G chemo, as you can see there. And this is the primary endpoint of the study. There is no overall survival difference at the moment. The follow-up is still relatively short, although a recent 5-year follow-up has again shown no difference here either. There are a number of interesting sub-studies in the gallium trial. This is one of them related to MRD. And what you can see here is that G chemo improves the level of MRD negativity in both the peripheral blood and in the bone marrow. What about when obinutuzumab is added to different chemotherapy backbones? So within this trial, investigators at an individual site could choose which chemotherapy backbone they used. The majority used bendamustine as the backbone chemotherapy. What you can see here is that actually the obinutuzumab adds actually relatively little in terms of MRD negativity rates to bendamustine, but when you add it to CHOP or CVP, the MRD negativity rates go from kind of roughly 75% or so up to 90%. So you can see there's an additional benefit in terms of MRD negativity to using obinutuzumab in these FL patients. Does MRD negativity matter? Well, that's an interesting question. Across the whole population, yes, it does. And here's the progression-free survival according to MRD status. There's a number of concerns with the gallium study. One of them was the infection-related morbidity and mortality in the bendamustine-treated patients. Here are the number of fatal adverse events, so grade 5 adverse events, divided out by the different arms of the study. So obviously they're divided by the 3 chemotherapy regimes and the 2 antibody backbones. And I suppose the key thing here is that if you use bendamustine in the frontline setting, the treatment-related mortality, interestingly, is up at about 5%, and particularly high when you're using obinutuzumab bendamustine. So you have to carefully select patients for bendamustine-based therapy. I think what you can see here, interestingly, is this is obviously time from cycle 1, day 1, right the way through in follow-up. And what's marked in blue are the patients who going through maintenance. So you can see here actually relatively few kind of infection-related or other causes of death during induction. But actually, when you look in the maintenance phase, actually much more in terms of events, particularly infection-related events in that space. But having said that, there are a variety of other events that are occurring that may well be, at least to some degree, unrelated to the therapy that patients have had. What about kind of infectious morbidity? What you can see here is the different regimes as mentioned, and the number of grade 3 to 5 infections according to both induction, maintenance, and then the observation period following it. And of course, a grade 3 event is an infection requiring admission into hospital. Grade 4 is a kind of a life-threatening event. Grade 5 is death. So what you can see here is that actually, and I've highlighted this in orange, the infection-related morbidity in the maintenance phase following bendamustine is quite high actually compared to following CHOP or CVP, and I'll show you a reason for that in a minute. So this is measuring people's kind of broadly speaking, people's immunity following the regime. So this is a kind of a fairly crude but important measure of T cell function in terms of measuring people's CD3 and CD4 counts. And again, you're dividing up by the different chemotherapy backbones, by the different antibody regimes, and then, of course, from baseline through to 36 months. And if you just focus on CHOP and CVP for a moment, you can see that there's no difference in terms of the CD3 and CD4 count over time. So actually having either antibody follow it with a CHOP or CVP backbone, you really don't drop your CD3 or CD4 levels with time. Compare that to bendamustine. What you can see here is that really there's a considerable dip in your CD3 and CD4 levels. Have a look at this graph here, and you can see once you reach the end of induction therapy, and indeed then in the kind of year post maintenance, patients are reaching a kind of average nadir of a CD4 count of around about 100 or so. So that's actually, I suppose, if you kind of take a different context, that's actually, the equivalent of relatively poorly controlled HIV actually in that setting. So I think it's really important if you use bendamustine or indeed then maintenance therapy afterwards, that people are really carefully monitored for, PCP, infectious risk, and that patients are carefully selected for bendamustine-based therapy. This is just dividing patients out by the arms of therapy. Now, the investigators got to choose what chemotherapy backbone they had, so this isn't randomized data at all. But what you can see here is that in the majority of patients that got bendamustine, because that was the most popular backbone, you can see the PFS benefit in those patients. What about fatal adverse events? What more could be learnt from the gallium study in terms of what regimes were used and who was actually vulnerable? Well, if you look at the fatal AEs, what you can see here is that the majority of them occurred in people with comorbidities or elderly people or those with one of those risk factors or poor performance status. If you divide patients up by age at baseline and then look to see whether there was a concern regarding infection-related mortality or mortality from any other reason, what you can see here is that if you were over 70 at enrollment, the TRM from bendamustine was 13% compared to 2 or 4% with CVP. Obviously, very few patients with CVP there. Compare that to the under 70s, and actually your TRM is down at 3% with bendamustine. So there's clearly a very distinct difference between those who are older receiving bendamustine-based therapy, and that certainly influences my practice in terms of who I would consider for bendamustine. Similarly, if you use obinutuzumab, although you've got a PFS benefit, there are higher rates of infection, infusion reactions, and cytopenias, and that's particularly as mentioned in the bendamustine treated group. Okay, so that's really giving a backbone to kind of some of the modern therapy that's used. can we improve on the way we give treatment in follicular lymphoma? Are there any ways we can give it in a kind of smarter fashion? This isn't published yet. This is just in abstract form. This is an Italian study looking to see whether PET and MRD can drive the decision-making process in terms of who needs maintenance and who doesn't. Now, I'm not going to go over this in detail because it's a complex slide, but this study was actually negative in terms of a PET and MRD driven strategy to try and improve on improve on minimizing maintenance for those who don't need it and making sure those that do get it. But you can see here that the investigational strategy didn't actually improve on 3-year progression-free survival. Just want to highlight this study. This is a UK study that's running at the moment. And what this study is doing is it's testing the question of whether patients who achieve PET negativity at the end of induction, so at the end of bendamustine CHOP or CVP, benefit from maintenance. So very briefly, I will just show you, this is the arm that is the kind of key potentially practice changing part of the study, where approximately 600 patients who achieve PET negativity at the end of therapy. Now we know that's a strongly good prognostic marker. Those patients are going to be randomized to ongoing maintenance here or stopping maintenance. So that's the kind of key part of the trial, and it's accruing patients at present. And I suppose what you're aiming to do is you're aiming to avoid early progression, but also minimizing toxicity. What happens if your patients progress early? Well, this is really important. This is a series of over 500 patients treated with R-CHOP in the frontline setting. What you can see here is that of the 20% or so who progressed within 2 years, their 5-year overall survival was 50%. So about 1 in 5 patients do particularly badly with follicular lymphoma. And that is compared to the 4 out of 5 who have an age and gender matched survival that's the same as the general population pretty much. So what this study shows is you can kind of pull out your bad players early on, and they're the ones who progress generally within 2 years of frontline therapy. Okay, so that's follicular lymphoma. What I'm just going to do is talk briefly about CLL in older patients. 78-year-old retired accountant. Again, this is a recent case I had. Type 2 diabetes, AF, knee replacement, a hip replacement, sorry, knee arthritis and a previous hip replacement. Again, pretty fit otherwise, minimal alcohol, lives with his wife on digoxin and lisinopril, and had a well-person blood test back in 2008 and had an isolated lymphocytosis, CD5, CD19 positive. A mantle cell lymphoma was looked for, but the translocation 1114 was negative and had no lymphadenopathy, so had been a stage A disease. Was observed therefore for 10 years and then developed progressive cytopenias and a lymphocytosis. And this is a most recent blood test where they're anemic. All the other obvious reversible causes of anemia were excluded in terms of iron deficiency, B12 folate deficiency, etc. And the patient was thrombocytopenia, had a lymphocyte count of over 300. Short doubling time of 10 months, and the blood film was repeated and actually showed no signs of hemolysis, no other signs of abnormalities, no pro-lymphocytic transformation. A CT scan was performed and showed a very big spleen and widespread moderate lymphadenopathy. TP53 mutation status was checked, and this is an important predictor of outcome with immunochemotherapy. And this was found to be not deleted or mutated. So the question here is, in a 78-year-old, what would be the kind of main treatment approaches or options here? So a few things just to talk about in this setting. First of all, that bendamustine actually is a good treatment in this setting. There's a trial called the MABEL trial, which was published in Hematology a couple of years ago, showing that patients who had received bendamustine rituximab had a superior complete response rate and overall response rate, and indeed progression-free survival over rituximab chlorambucil, which it was compared to in this study. So this is the efficacy in the frontline treatment group. What you can see here is that the median progression-free survival with the bendamustine treated patients was about 40 months. So very reasonable, actually, treatment option in that setting. I'm going to talk about the CLL11 study, and then subsequently I'm going to talk about some more recent data in this setting. So this is a study published in the New England Journal now 6 years ago of chlorambucil as a control arm compared to chlorambucil rituximab and chlorambucil obinutuzumab. So three-way randomization, 600 patients in the first randomization, and additional patients were added in to a second randomization of chlorambucil and with either obinutuzumab or rituximab. So this is the this is a baseline. These are the kind of main headlines. The overall response rate was much higher with obinutuzumab chlorambucil as compared to either chlorambucil by itself or chlorambucil with rituximab. You can see here that the depth of response was also higher. So in the peripheral blood, the MRD negativity rates were over 30%, and the bone marrow negativity rates were 17% with chlorambucil obinutuzumab. Now, the initial publication showed a progression-free survival advantage of the obinutuzumab, and then obviously patients were followed up in the longer term. This is an abstract from 2 years ago now, showing the long-term follow-up of this study, the CLL11 study. And if you look at the Kaplan-Meier curves on the right-hand side, what you can see here is that this is comparing rituximab chlorambucil with obinutuzumab chlorambucil. And you can see that there's a marked progression-free survival advantage, time to next treatment advantage. And interestingly, at the long-term follow-up, there is actually an overall survival advantage for having obinutuzumab chlorambucil ahead of rituximab chlorambucil. So I think that's really important, that actually patients benefit not only through progression-free survival, but also they live longer now across a population if patients have the antibody substituted in the frontline setting. Okay, so I think that's a kind of key backbone studies that published kind of a few years ago. Obviously, the field is moving very quickly, and there are a number of novel therapies that have been, I suppose, made available or developed in the frontline setting. This is just a summary slide of some of the studies looking at ibrutinib, which is obviously a first generation BTK inhibitor. There's a study called the RESONATE-2 study, which certainly established ibrutinib monotherapy as significantly superior above chlorambucil alone as monotherapy. There's a study called the ECOG 1912 study, which is a big American academic study, which compared ibrutinib rituximab to FCR. And there's a PFS advantage particularly in those who have unmutated immunoglobulin gene mutation status. And there's a study of ibrutinib versus bendamustine, and again, big progression-free survival advantage for ibrutinib. And then there's a non-randomized phase 2 study, which again shows very nice durable responses in the frontline setting. So ibrutinib actually is not available in lots of countries as frontline therapy, but for those countries that it is available, it's an effective option here. What about newer randomized clinical trials comparing novel strategies with chlorambucil obinutuzumab? I've obviously shown you chlorambucil obinutuzumab being effective. Are there anything that's better? So this is venetoclax with obinutuzumab as the new investigational arm in the CLL14 trial. Over 400 patients randomized in this German-led study, taking first-line patients had to either be unfit through comorbidity, so SIRS score of greater than 6, or have impaired creatinine clearance, and they had fixed duration therapy of either of those treatments. Just to go over the kind of venetoclax obinutuzumab schema, you had the initial doses of obinutuzumab to reduce your tumor lysis syndrome risk, and then venetoclax was then added in a ramp-up phase and continued for a year. I'll just skip over that. We've mentioned that. This was a group of patients who were just over 70 in both arms. The baseline characteristics were well matched. About a quarter of patients had, just under a quarter of patients had TP53 deletion or mutation. And interestingly, quite a relatively unfit group in terms of comorbidities, with a median SIRS score of 8 or 9. The response rates, including the complete response rates, were much higher with venetoclax treated patients. So you can see here 50% versus 23%, overall 85 versus 70. And this was also true for MRD negativity. Now, I've shown you the MRD negativity from the previous study, the CLL11 study. This study shows that although you get MRD negativity, which again was similar with the obinutuzumab chlorambucil in both blood and bone marrow, the rates are considerably higher with venetoclax obinutuzumab. And this has led to a progression-free survival advantage. And actually at ASH recently, the 4-year update showed an ongoing considerable PFS benefit for venetoclax obinutuzumab. What was shown here also, though, is that patients who had P53 mutations didn't do quite so well, actually in both arms, but interestingly, fixed duration therapy in this setting for P53 deleted patients wasn't potentially quite as good as it could have been. Also, immunoglobulin gene mutation status also differentiates patient outcome. There's no overall survival advantage in this study. You can see here that at this follow-up point, those curves overlay each other. And of course, it's a frontline CLL study, so it may take some time for any survival advantage to be demonstrated. What about the toxicity profile? Well, patients who have venetoclax, actually very similar toxicities in terms of some cytopenias, some infections, but actually generally very well tolerated if the ramp-up phase is managed carefully. So that's the CLL14 study. That's provided certainly a new option in the frontline setting. What about newer BTK inhibitors? So this is again a recently published study in the Lancet comparing obinutuzumab chlorambucil with a novel BTK inhibitor, so acalabrutinib, a second-generation BTK inhibitor, or acalabrutinib with obinutuzumab. A large randomized trial in the frontline setting, a fairly similar demographic to the CLL14 study, median age of about 70. Again, the inclusion criteria is generally pretty similar. And again, a small proportion of patients with high-risk genetic features. I'll just skip over that slide. So the progression-free survival in this study, again, here's the obinutuzumab chlorambucil, and the median PFS is round about, I mean, it's not quite reached here, but it's around about 2 years. But at 2 years follow-up, there's a marked difference in PFS between chlorambucil obinutuzumab with acalabrutinib and acalabrutinib obinutuzumab. And that advantage of the acalabrutinib treated patients was seen across a range of, well, pretty much all subgroups. You can see there, including those with immunoglobulin gene unmutated disease and other high-risk features like complex karyotype and P53. As you might expect, the response rates were higher, and actually particularly the CR rates were higher when you added in obinutuzumab. At present, the follow-up is pretty short, and of course, you know, a lot of the patients going into these studies would have had crossover to acalabrutinib and indeed other therapies available. So we wait to see whether there's a survival advantage in the longer term. In terms of safety, obviously a BTK inhibitor has a slightly different safety profile to consider compared to say, for example, a BCL2 inhibitor, but there are AEs associated with it. Here's the kind of general AE profile. Certainly with BTK inhibitors, diarrhea, cytopenias, arthralgia can be side effects that are notable. And the other ones to note with acalabrutinib, the so-called events of special interest, which is a kind of BTK-related adverse event profile. Atrial fibrillation is one of the main things to consider. Actually, the rates are generally pretty low here, down at 3%. Hypertension, certainly with ibrutinib, goes up to kind of 15 to 20% in time. Relatively short follow-up here, but you can see the hypertension rates are fairly low, and major bleeding rates low. Infections are kind of one of the main things to look out for when you're managing patients on a BTK inhibitor. So that's a bit of a quick kind of whistle-stop tour through frontline treatment of follicular lymphoma and CL and older patients with CLL. I'll stop talking there, but thank you again for the invitation, and I hope that was of interest. And yeah, happy to take any questions.
Thank you very much, Toby. It was a wonderful, very comprehensive, and I'm sure it would help us all in the clinics. So a question for you from our hematologist, Dr. Islamabad, is how would you treat elderly CLL patients with cardiac disease? Would you still like to select ibrutinib?
Yeah, it's a good question. Obviously, it depends on the availability of your therapies, of course. I think if to kind of answer the question, if everything was available at your disposal and somebody had cardiac disease, then based on the information that we know about, particularly ibrutinib, I didn't go into it in great detail, but there's obviously quite a lot of non-clinical trial data with ibrutinib showing some quite concerning toxicities. So I think if I had the option, I would probably use venetoclax-based therapy, probably with obinutuzumab based on the CLL14 trial, if everything was at my disposal, let's put it that way.
Thank you very much, Toby, for being with us, and we really appreciate spending time on Saturday. Thank you very much. We move on to our next talk.
Thank you for having me.
The Lefty. Thank you very much. So the next speaker is Professor Leslie ANDRITSOS from University of New Mexico, United States of America. She is going to put us wiser about hairy cell leukemia. She has a special interest in hairy cell leukemia, and she has an experience of 2 decades of treating hematological malignancies, especially lymphoid malignancies. Over to Professor Leslie from Mexico. Thank you very much for being with us early in the morning on Saturday.
Yes, it is. The sun has not yet risen here. It's quite early, but I really appreciate the invitation. I'm honored to be here. I will start sharing my screen.
So on the horizontal bar downwards, there is the share screen option. Thank you.
Okay.
Yes, we can see your slides.
Excellent. Oops. Just a little preview. All right. These are my disclosures, and I will be discussing off-label use of a few agents. So I frequently get asked, why do I study hairy cell leukemia? Because it's a rare disease, but also there are already highly effective therapies. And so sometimes it seems like maybe there's not a need to look at this disease, but we know that the incidence appears to be increasing, at least in the US. Many patients are living longer with multiple relapses, and we need to understand the disease biology to inform better treatments for these patients that have had potentially multiple courses of purinucleoside analogs, and you may not want to use that type of therapy again in a relapsing patient. So this is just an overview of the discussion. I'll be giving a little bit of a historical overview and then some talk about the epidemiology and incidence in the US, a brief discussion of the biology, and then some discussion about the new consensus guidelines, novel therapeutics, and some research efforts. And similar to Dr. EYRE, I'd like to start with a case because I think it's very demonstrative of some of the challenges that we're facing right now. So this was a patient of mine, 52-year-old man who presented to the emergency department with pneumonia and had massive splenomegaly and pancytopenia. And his bone marrow biopsy was hypocellular with 90% involvement by a monoclonal population of B lymphocytes with a classic hairy cell leukemia immunophenotype. Can everyone see my cursor? So and the key here is the CD25, because that is one of the first studies that the pathologist used to differentiate between classical and variant hairy cell leukemia. And so he appeared to have a classical immunophenotype. However, his BRAF V600E mutation was negative. And so the question comes up, what is his diagnosis? Because there are many who believe that for a diagnosis of classical hairy cell leukemia, the BRAF mutation must be positive. So just a brief history about hairy cell leukemia, because Bertha Barancli, I don't know if Dr. Awan is on the seminar today, but Bertha Barancli was one of the hematologists at Ohio State University. And so I've included a picture here, but the disease was first observed in 1923, I think, when people first started using microscopes to look at peripheral blood. And at the time they called it leukemic reticuloendotheliosis, which is a terminology that has kind of, you kind of still see here and there. But Dr. Barancli more completely characterized this in 1958. And I think it's really important to emphasize that when this disease was first discovered, it was uniformly fatal, and the median survival was only 4 years. There really was an urgent need to help people get better treatments. But in 1984, interferon alpha was studied in the disease and led to rapid hematological improvement. And you really started seeing the natural history of the disease changing. And then that really took off when the purinucleoside analogs were first used. And those basically transformed hairy cell leukemia into a chronic disease with sometimes normal life expectancy compared to age-matched controls. This is a timeline that I put together a few years ago. I think we're going to need to add some new discoveries to it. But you can see that, you know, for a long time after the initial discovery of the disease, nothing was really happening. In the 1950s, people were using splenectomy and corticosteroids. And then, you know, we sort of got the terminology hairy cell leukemia going. A clinical staging system was developed in 1982, which was mostly focused on splenomegaly and hemoglobin at the time of diagnosis. But during this time period, there was just an enormous expansion in the number of available therapies. And then starting in the 2000s and on, there really was just an explosion in the development of new therapies. And I'd like to draw your attention to 2008, and that is when variant hairy cell leukemia was reclassified, where it's no longer considered biologically related to classical hairy cell leukemia. And I think that was a very important change because moving forward, the clinical trials were very clear about the difference between patients with classical and variant hairy cell and their responses to therapy. It is quite rare. It's only about 2% of all leukemias, with about 1,000 new cases diagnosed in the US annually. The median age at diagnosis is a little bit younger than some of the other lymphoproliferative disorders. It's about 55, with a 4-to-1 male predominance. There is a higher incidence among Caucasians, especially of Jewish ancestry, and a lower incidence among Asian, African, and Arab populations. There are some possible associations. I don't know, if any of these are tried and true, but farming and especially exposure to pesticides and herbicides and diesel exposure, and potentially exposure to ionizing radiation, and then a possible inverse exposure history, which is smoking appears to be sort of protective. There was a European study that showed that people who smoked were less likely to develop hairy cell leukemia. We're not advocating that anybody start smoking, but it's an interesting observation. So moving on to a few words about the biology of hairy cell. I think it's fascinating that they're hairy. This is an indication of intrinsic cellular activation. The cortical cytoskeleton is in a state of constant active reorganization, and the cells develop this membrane ruffling and microvilli formation. One of the great hematologists also at Ohio State, Clara Bloomfield, said that all important scientific discoveries in hematology begin at the bedside, and then you take them back to the lab as opposed to the other way around. This was actually an early clue into the biology of hairy cell, that there was constitutive activation of the MAP kinase pathway, and that paper was published back in 2003, before any of the subsequent work was even considered. So in spite of a lot of progress, the pathogenesis is still not completely understood. It's proposed to arise from a late activated memory B cell and these cells somehow acquire a BRAF V600E mutation that activates the RAF-MEK-ERK signaling pathway. There are a number of other mutations that are much less commonly described in both classical and variant hairy cell leukemia. And I wanted to let you know that a small percentage of patients will develop monosomy 7 or be diagnosed initially with monosomy 7, and that does appear to have a poor prognostic indication. And so a lot of times in the US, people do not perform cytogenetics on patients with hairy cell leukemia, but that's something that could be considered if you have a patient with, for example, primary refractory disease. So, one of the major developments in the last decade in hairy cell was the discovery of BRAF V600E mutations. This work was done by Dr. Tiachi and his colleagues in 2011. It basically started with whole exome sequencing on one patient's CD19 selected hairy cell, and they had an additional 48 patients with classical hairy cell. And so they prepared shotgun libraries from leukemic and non-leukemic genomic DNA, identified candidate somatic mutations, performed sequencing to verify the candidate mutations, and identified that 47 of the patient samples had a BRAF V600E mutation. And they also used a BRAF inhibitor in vitro to demonstrate dephosphorylation of phospho-MEK and ERK. So we know that the BRAF mutation constitutively activates BRAF, leading to oncogenic signaling through the MEK-ERK cascade. And when you use inhibitors, both in vitro and in vivo, you get dephosphorylation of MEK-ERK, silencing of the pathway's transcriptional output, loss of hairy cell leukemia gene expression, and eventually the cells undergo apoptosis. And that's just a cartoon representation of that pathway showing the potential therapeutic opportunities along the pathway. And vemurafenib and dabrafenib have already been studied in hairy cell, and a number of MEK inhibitors as well. And I'll discuss that a little bit more later. So the support for the theory that these mutations are pathogenic is that we see these mutations in the majority of classical hairy cell leukemia. They're present in the entire tumor clone. It is a somatic mutation, and there's high stability at relapse, meaning when patients relapse, they will still have the mutation, whatever else may change. So this wonderful study was done by Dr. Abdelwahad and his team, where they looked for pre-leukemic cells of origin for hairy cell leukemia. So they took 14 patient samples and flow sorted them along the sort of hematopoietic developmental states, and assayed each point of development for the BRAF V600E mutation. And they were able to identify BRAF V600E mutations in hematopoietic stem cells, as well as pro-B cells and hairy cells. Interestingly, the hematopoietic stem cells were phenotypically normal, so they did not appear to have any phenotypic changes. and mouse models transfected with the mutant HSCs went on to develop a hematopoietic disorder similar to hairy cell. And the murine models where BRAF inhibitors were used did not develop leukemia. And so that is sort of strong support that there is a abnormal hematopoietic stem cell that is the leukemic cell of origin. I wanted to show this slide. It's a little bit busy, but just to show that there really is a large number of genomic alterations seen across some of the lymphoproliferative disorders. Some of these are shared by both classical and variant hairy cell leukemia, and some of them are really sort of only exclusively seen. And so I think that some of these will help us actually diagnostically as we try to get closer to a more refined approach to diagnosis and risk stratification in hairy cell, because we know many of these genomic alterations confer a poor prognosis. There really wasn't a lot of time to go into detail about variant hairy cell leukemia. It's a very complicated disease, actually. It's characterized by a more aggressive clinical course. By definition, it is BRAF V600E negative. And originally it was felt to always be CD25 negative, but I will put some caveats in there that patients who receive treatment may lose their CD25 expression. And also there may be some forms of variant that are actually CD25 positive. So we'll get to that in just a minute, but there are all these subsets of variants. So some of these patients have a classical immunophenotype, but they're negative for BRAF V600E, and they may utilize HB434, which confers an inferior prognosis. Some patients have a variant immunophenotype with the same gene usage. Some have MAP2K1 mutations, and there are also very likely to be new epigenetic variants, and that is something that Christopher Oakes and his team at Ohio State are working on currently. So as I said earlier, hairy cell classical and variant are now considered to be biologically distinct entities by the World Health Organization going back to 2008. And it's currently located in the splenic B-cell leukemias and lymphomas, unclassifiable. But we know that probably more than one variant exists, and this may be a disease that's going to eventually get its own classification. So I wanted to let everybody know that there are consensus guidelines for hairy cell leukemia diagnosis, response assessment, and treatment. These were published in Blood, and this basically represents the combined efforts of the entire Hairy Cell Leukemia Foundation scientific team over a number of annual meetings, sort of helping to define this. It was considered to be really important. I think it's one of the best things Michael Griever has done for hairy cell leukemia, because before that, there was really not a consensus among the investigators. So as I said, these are the first official standards for diagnosis, indications for treatment, response assessments. We did put in some recommendations for first-line therapy, and these recommendations will need to be updated, as well as treatment at relapse. So these are the diagnostic considerations, which were reviewed very nicely earlier in this seminar. And so these are the qualifications for a diagnosis of classical hairy cell leukemia versus variant. And so variant patients should be CD25 negative and CD123 negative in most cases. In the guidelines, we did not address the BRAF mutation status or other mutations in variant hairy cell leukemia. And again, I think that over time, there will need to be separate consensus guidelines for variant. So when do you need to treat your patient? So I did include a couple of things in here that were not in the consensus guidelines, but have emerged more recently as problems that patients with hairy cell can tend to have. So the first is anemia with a hemoglobin of less than 11, platelet count less than 100,000, absolute neutrophil count platelet count less than 100,000, and absolute neutrophil count less than 1,000, and then symptomatic disease. So of course, splenomegaly. some patients do develop lymphadenopathy. It's not as common, but it can be symptomatic similar to any other lymphoproliferative disorder. And I wanted to mention that some patients with hairy cell leukemia get skeletal involvement. And so skeletal involvement with bone pain, I consider symptomatic disease. And this usually responds to the same treatment that you would give for, primarily marrow disease. And so I did include that even though it's not in the consensus guidelines. And then a more difficult symptom to manage and assess is constitutional symptoms. So when patients are having fatigue and weight loss and, sometimes night sweats, a lot of times it becomes the patient's decision about whether they feel like they're feeling sick enough for treatment. And so we don't really have great tests for that. And so I basically feel that if the patient is ill enough that these symptoms are causing problems with their activities of daily living or preventing them from working, then those are good indications for therapy. And I wanted to discuss a little bit about the response assessments because this was one of the more controversial aspects of the consensus guidelines. But I think many people would not even notice that this was in there when they were reading it. So for a complete response, you need normalization of blood counts and resolution of splenomegaly. And then on the bone marrow biopsy, absence of morphological evidence of hairy cell by H&E staining. I think most of the time, now, when we get our bone marrow results, there is not a detailed review of the H&E stain, and most of the disease assessment is based on immunohistochemistry. And so this is a point of confusion that we'll probably need to address with the next consensus guidelines, because I think most patient samples are coming back exclusively with IHC. And then the other thing is that we need to address is minimal residual disease, because there is currently not a consensus around the definition of this. And I put in quotes, which I won't read to you, but this is how MRD was discussed in the guidelines, and we need formal recommendations regarding what analysis to use and what percentage of bone marrow is considered measurable residual disease. And I don't think I need to go through this because we just talked about this, but the MRD assessment, I think, is one of the this year's topics that the Hairy Cell Foundation researchers are going to be addressing. So hopefully you will be seeing a publication on consensus guidelines for MRD. And so I like to draw people's attention to this particular phenomenon in hairy cell leukemia. So when you treat patients with any therapy, basically, they lose their hairy projections, and they also lose surface antigens. So CD25 and CD123 will be lost. And so the reason why I think this is important is because sometimes people move between institutions. So you may have a patient who was diagnosed and treated at one institution, moves for some reason or another, gets another bone marrow biopsy and is diagnosed as having variant hairy cell leukemia because their CD25 is negative. And this can lead to some confusion. And so I think it's important to note that once patients are treated, they will no longer have hairy projections, and that is a precursor to apoptosis. And this is a nice graphic that Dr. Fellini and colleagues did looking at hairy projections before and after vemurafenib in classical and variant hairy cell, and you can see that the variants do not lose their hair. So a few words about treatment. I think this is really important right now because first of all, there are a lot of treatment options. And secondly, this is an important consideration during our current global pandemic because the best treatment for hairy cell leukemia is incredibly immunosuppressive. So the purine nucleoside analogs, including cladribine and pentostatin, are both incredibly effective in both the upfront and relapse setting. And I put a little asterisk there because this is the highest risk time for the patient. So if somebody will die from hairy cell leukemia, it's oftentimes when they're first getting induction with a PNA because many times they arrive to the hospital ill with an infection. And when you give purine analogs, there is an initial period of severe myelosuppression where the neutrophil count will go down before it starts to normalize. And also when you give the PNAs, you'll have profound lymphopenia as well, which is quite global. And the lymphopenia is usually prolonged and may take up to a year or longer to resolve. And so it is really important to consider how you're treating patients and how they're being managed, because oftentimes they resemble acute leukemics in that first treatment period and need very close observation. The overall response rate with PNAs is about 100%, with about 70 to 90% of patients achieving a complete remission. And the 5-year progression-free survival across studies is about 70%. It's very important to note that this has resulted in normalization of life expectancy. And so because patients are not cured by this chemotherapy, but usually have a wonderful response, they're going to live a long time, and at least 40% of patients are going to relapse in a way that requires subsequent therapy. So I wanted to discuss briefly what I consider to be a practice-changing study, which was done by Dr. Kreitman at NIH, looking at randomizing patients to receiving upfront versus delayed rituximab. So these patients got cladribine intravenously days 1 through 5 and 8 weekly doses of rituximab beginning day 1. He calls that the CDAR regimen, or rituximab beginning 6 months after completion of therapy if they had MRD detected either by blood or marrow flow cytometry or immunohistochemistry. 68 previously untreated patients were randomly assigned. And at 6 months after the CDAR chemotherapy, the complete response rates were 100% versus 88% in patients that just got cladribine. And the MRD-free CR rates were 97% versus 24%. So quite significant improvement in concurrent versus sequential. And then at 96 months of median follow-up, 94% of the patients that got CDAR remained MRD-free versus 12% of the other group. The one thing we've always worried about is whether adding upfront rituximab will increase the toxicity of the treatment. And it was very nice to see that while this regimen did have significantly higher rates of grade 3 and 4 thrombocytopenia, and some patients needed transfusion support, there were no other significant toxicities and no patients died during induction therapy. And so, for patients that are fit, this is probably the approach that most people would take at this time, would be a purine analog plus rituximab concurrently. So, but some of these patients have had chemotherapy. They may have had multiple cycles of a purine analog. We're very fortunate that we have a whole panel of other therapies to consider, and I've made a list of them here. The cartoon on the right is a picture of moxetumomab pseudotox, which is a recombinant immunotoxin, and I'll present their approval study in just a minute. But lots of different varying approaches to treating hairy cell. So the first thing I'd like to cover is BRAF inhibition. The first report was in the New England Journal of Medicine, and it was actually the combined results of an Italian study and a US study that had been going on kind of at the same time. So the groups decided to combine their reporting to get the information out there. So it was all classical hairy cell leukemia patients who were relapsed or refractory to purine analogs. The patients got vemurafenib 960 milligrams twice a day. That is actually the melanoma dosing. So there were not dose finding studies just in hairy cell leukemia. In the Italian study, they were treated for a median of 16 weeks and 18 weeks in the US study, with the primary endpoints being complete remission or overall response rate, depending on the location of treatment. So the overall response rate was quite high at 8 weeks, 96%, and 100% after 12 weeks in the US study. The CR rates 35% and 42% respectively. The median relapse-free survival was 19 months in patients who did achieve a CR. Patients who only achieved a partial response had a relapse-free survival of only 6 months. The median treatment-free survival was 25 and 18 months. Some patients had adverse events requiring dose reductions, most commonly being rash, arthralgias, or arthritis. Anybody who's used vemurafenib knows that some of these rashes can be quite significant. And the other problem was that about 14% of patients developed secondary cutaneous tumors, and these are usually squamous cell carcinomas. And so we usually do skin surveys for patients on therapy quite frequently to make sure that they're not developing skin cancer. So, you know, the hope had been that people would, patients receiving vemurafenib would achieve a better MRD negative status, but it turns out adding rituximab to vemurafenib can achieve that. So Dr. Tiachi and his colleagues published this abstract at EHA looking at 31 patients with relapsed refractory hairy cell who got vemurafenib for a total of 8 weeks, so a short treatment duration. And during this time, they got rituximab every 2 weeks, followed by rituximab consolidation at the completion of vemurafenib treatment. And 26 to 27 evaluable patients achieved a CR, and as early as 4 weeks after initiation of therapy in 63% of patients. The MRD testing was negative in the bone marrow of 65% of the patients that were evaluable for that. And the progression-free survival at a median follow-up of 29 months was 83%. And I'll show you a graph in just a second, but the progressions occurred in patients who were MRD positive. So it does appear that having residual bone marrow disease at the completion of therapy is a significant risk factor for disease progression. And so we do advocate checking a bone marrow biopsy after treatment is complete, because these are patients that probably will need to be followed much more carefully and treated earlier than their MRD negative counterparts. This is a point of controversy in the US. A lot of people do not do bone marrow biopsies at the end of treatment if the patient has achieved a complete hematological remission. But I think that this graph will sort of show that the patients who are MRD positive really fall off the cliff. And so when you separate out, you know, from all patients in figure 1A to the patients who are MRD negative versus MRD positive, there's a clear and significant difference. So that, I think, gives more impetus to checking the bone marrow when treatment is done. So a word about immunotoxin conjugates. So moxetumomab pasudotox is a recombinant CD22 targeting immunotoxin, which is conjugated to a Pseudomonas exotoxin. CD22 is highly expressed on hairy cells, as we saw earlier. So it's a very reasonable target. So Dr. Kreitman treated relapsed refractory patients who had received at least 2 prior therapies, including a purine analog with Moxi. The treatment schedule is days 1, 3, and 5. Every 28 days for up to 6 cycles. And he found an overall response rate of 75% with a durable CR rate of 30% and an overall CR rate of 41% at the end of treatment. 64%, so 80% of the patients achieved a hematological remission. And among the complete responders, 85% were negative for MRD by IHC. So this is clearly a highly effective therapy for relapsed refractory patients. Dr. Kreitman is currently performing a clinical trial combining Moxi with rituximab because the thinking here is that it's possible that patients who have had prior Pseudomonas infections may have preformed antibodies, and that may be one of the reasons why some people do not respond to Moxi. And so they'll get rituximab concurrently with moxetumomab. And so we're anxiously awaiting the results of that study. I also wanted to draw your attention to the fact that there are significant treatment-related serious adverse events, one being hemolytic uremic syndrome and the other being capillary leak syndrome. And so there is a very detailed supportive care regimen to try to prevent patients from developing these. And it's also important to note that these can happen during any cycle of therapy. So even if a patient has done great with their first and second cycles of treatment, they can develop either of these during cycle 3 or subsequent cycles. And so they do require close laboratory monitoring as well as physical exams and weighing to evaluate for capillary leak syndrome. The company that currently has moxetumomab has a program where if you're going to treat a patient, you can contact them and they will get you in touch with somebody who is really familiar with the drug, so you can kind of talk through some of these things ahead of time. And full disclosure, I'm one of those speakers. It's called a peer-to-peer discussion, but that resource is available if you have a patient who may have baseline renal insufficiency or some other reason why you may be worried that they would be more likely to have a serious adverse event with Moxi. So what about Rituxan? So, we saw earlier that the anti-CD20s are extremely effective therapies in indolent lymphomas. And I think it's kind of forgotten, honestly, very often in hairy cell leukemia as a single agent. It can be effective. And in fact, there are some groups in the US that use this as their initial upfront therapy to try to get patients quickly better with better bone marrow function before they get purine analogs. That data has not been published. That's a personal communication, but I think it's used rather frequently, and there's good reasons to use it. So there was a very small study back in 2003, only 15 patients. They got 8 weekly doses of Rituxan, and then if they didn't achieve a complete response by the definitions at that time, they could get an additional 4 doses. The overall response rate was 80%, which is pretty good for a single agent in this disease. 8 patients achieved a CR, and some patients also had MRD negativity by the definitions at that time. And then the patients did tend to respond, but of the responders, the disease progression was, not as early as you might expect. So 8, 12, 18, 23, and 39 months from the start of therapy. Importantly, no infectious episodes were observed. And I also wanted to mention that if you look this up, there are a number of case reports of hairy cell leukemia patients developing grade 4 thrombocytopenia after their first dose of Rituxan. So this is just a word of caution that you should probably check blood counts early after single agent Rituxan to make sure that this has not happened. It's probably an immunological phenomenon, and it usually just resolves spontaneously with observation. So we know that BCR pathway inhibitors are highly effective in other hematological malignancies that rely on that pathway for survival. There is an ongoing phase 2 study of ibrutinib in both hairy cell classical and variant. The most recent publication detailed 28 total patients, 17 of them with relapsed hairy cell. There were 2 different doses used. The study started at 420 milligrams a day and then increased to 80 milligrams per day. And there was actually no difference seen with respect to response in the higher dosing. The drug takes time to work in hairy cell. And so I think that when the study initially started, the assessments were done at 6 months, but then that was extended to 8 months because many patients were still responding and probably had not achieved their maximal benefit. So when this report was published, 4 patients had achieved a CR, 9 patients had achieved a PR, and then a number of patients had achieved stable disease, which, you know, in a person with a lot of comorbidities or other problems, sometimes stable disease is pretty good. And patients seem to be able to stay on this drug for a long time with, you know, appropriate monitoring, as Dr. EYRE was saying earlier, for atrial fibrillation and hypertension and arthralgias. Also, the BRAF inhibitors have been paired with MEK inhibitors because the MEK pathway is considered a potential alternate route for development of resistance to BRAF inhibition. There was a fairly large study published recently looking at dabrafenib plus trametinib. So trametinib is the MEK inhibitor, and 43 patients. The overall response rate was 78%, with 49% of those patients achieving a CR and a 12-month progression-free survival of 98%. But this was a fairly toxic combination. 49% of patients had grade 3 or 4 adverse events, and adverse events were the leading cause of therapy discontinuation. So I think it's unclear at this time, whether this is going to be a strategy moving forward, because trametinib can cause ocular toxicities, cardiotoxicities, and other problems. So this brings me to, I think, the biggest question that we're all asking ourselves and patients are asking, which is, how do you select therapy during the pandemic? Because we know that the purine nucleoside analogs are still the most effective therapies for hairy cell, but they're also highly immunosuppressive and the effects may be prolonged. So there are different schools of thoughts on this. Some people feel that the best thing you can do for your patient is get them into a really good remission. And others say, you know, you could probably do something that's more of a temporizing approach to stabilize the patient until they're able to get a COVID vaccine. And then you can kind of give them more intensive therapy if needed. And the other thing that we're concerned about is we don't know if anti-CD20 is going to lead to an impaired vaccine response. And so at this time, some of the things that have been discussed is for patients who can watch and wait, do that as long as possible. But some people require immediate therapy. And so the non-immunosuppressive therapies are probably, single agent vemurafenib is probably the least immunosuppressive of all the therapies. I put ibrutinib on this list because, you know, it's an interesting drug, but it does impair normal B cell function. And so this may be a drug that could interfere with a vaccine response. But if somebody did not have other good options, I think that should be on the list because it doesn't inhibit T cells. And then don't forget about interferon, because that is still an effective therapy in hairy cell leukemia. And I think it's actually one of the therapies that will improve the blood counts the fastest. And then with a question mark, I put venetoclax because I know people are using it, but there have not been publications. So I hear anecdotal stories of people giving patients venetoclax. I don't think we can recommend that outside of any data, but I know that some people are giving that to their hairy cell patients. I would say that's something that we really need to study in combination with something else. So I think we're fortunate that we have 3 drug companies that have worked very hard to quickly get some vaccines to the patients. And so my approach right now is I'm trying to wait on treatment until patients have had a COVID-19 vaccine. And then we can just go ahead and administer a purine analog with Rituxan in fit patients if they still need therapy after that. If they need immediate therapy, I'm trying to stick with single agent vemurafenib. And hopefully that will get people to a place where they can get their vaccine and then get whatever they need. If they're BRAF negative, the options kind of dwindle. So for the variant hairy cell leukemia patients, I think it becomes more difficult, and choice of therapy, you know, is probably going to require something that actually is immunosuppressive. So just quickly, I wanted to let everyone know that there is a patient data registry in hairy cell leukemia. So this was actually the patients in the Hairy Cell Foundation. So the foundation is run by patients, and they wanted us to build them a Google of hairy cells so that they could kind of query, what happens to hairy cell leukemia patients. But because of, HIPAA guidelines and research requirements, we were not able to do that. But we did build a registry that is, the data is currently housed at Ohio State and managed by the BMI specialists there, with immediate goals of increasing knowledge of the disease. For example, what happens to women who are pregnant when they're diagnosed with hairy cell leukemia. There's a lot that's not known. And then also, of course, to improve the lives of patients by improving outcomes and treatments. The future goal really is to use this registry to facilitate clinical and translational research and ultimately to provide a platform for a tissue biorepository. So these are the centers that are currently participating. We're very fortunate to have an international collaboration. The biggest hurdle has been regulatory approvals at many of the centers, and so we're at this moment rolling it out to centers that are able to, get the regulatory approval, because some centers are very, very restrictive and others not as much. We have been contacted by the Charity Hospital in Berlin with an inquiry about potentially participating, and they're looking at their institutional review, as is Memorial Sloan Kettering. And then we have a website. I went past that kind of quickly, but there is a registry portal on the website. Currently, this is only enrolling US patients. We don't have IRB approval to do it this way outside of the US, but basically researchers at those listed institutions will basically tell their patients to go to the Hairy Cell Foundation website if they're interested in participating. So this is our enrollment as of October. We have 462 consented patients. We've entered medical records on almost 400 of them. We only have 8 patients waiting for their medical records to be entered, and then about 50 of them we're still awaiting their records to be sent to us. So it's kind of hard to describe how much work went into this, consent and data entry process, but it is a living document and we update it continuously. And so I think that we're finally getting to a point where we have enough patients where we'll be able to achieve statistical power to ask and answer some of these questions. People who want to submit proposals for use of the registry data basically just email their proposal to the Hairy Cell Foundation. We meet quarterly virtually for the scientific review committee. We have a delegate from each participating site, so an investigator. There's also leadership from the Hairy Cell Foundation and a patient representative, and then we have a biostatistician and scientific collaborators. And I just listed examples of some of the protocols that we've approved. So you can see that there's really a variety of different interests in looking at patients in the registry to answer some of these questions that we really have never been able to look at before. And Dr. Matthew Cross is currently working on looking at skeletal involvement in hairy cell. As I said before, the data is entered manually. It's housed at Ohio State University. We've made it as safe as possible. It's de-identified at the time of data entry, and each patient has a unique patient ID number. All of the data is verified using source data, so we will get the original bone marrow biopsy report to enter the data from that, and then we're able to query all of the data in the registry via a very powerful query portal. This is a centralized architecture showing the groups that are currently participating and how we kind of firewall the data. We don't need to go into too much detail into that, but basically each site has a staging database where they enter their data, and as soon as it's entered, the data becomes de-identified and merged into the registry database. This is just a screenshot of the manual data entry portal. We've tried to make it as easy as possible. I just wanted to give an example of a study that is already linked to the patient data registry, which is we're doing a quality of life study. So this is the first prospective longitudinal quality of life study in hairy cell leukemia. We started enrolling patients in 2017. We've consented 259 patients, which is incredible. And we've got a couple of other health systems hopefully joining us. And so you can see that as time goes on. So patients complete their baseline questionnaires and they have a follow-up questionnaire every 6 months for up to 5 years, as long as they're in the study. So we've had 225 patients complete their baseline questionnaire and then a large number of patients in follow-up. This is a list of the study questionnaires. There is some overlap and redundancy, but we were trying to use validated, currently available scoring systems. The one thing that we did that's new is hairy cell leukemia patient concerns, which is trying to get at challenges that affect quality of life in people with a rare disease. They do their questionnaires either on paper or in REDCap. We can do all of this electronically if we need to. The survey data is connected with the patient data registry, and each site has its own REDCap account to enter its own data. Currently, only patients enrolled in the data registry are invited to participate, but we're thinking about amending the protocol to include patients that have available longitudinal data. So this is a summary of our initial findings when we first did a data analysis, and we're awaiting our updated data analysis, but we found that the hairy cell patients have a better health-related quality of life. And this was associated with being older than age 65, and the patients who were physically active scored higher. And being in complete remission had a significant impact on quality of life as well. The patients who had newly diagnosed hairy cell leukemia actually reported lower physical and emotional well-being and lower functional well-being. And so it looks like really the time that's the hardest for the hairy cell patients is at diagnosis, and then over time the quality of life steadily increases to be actually higher than not only matched cancer controls, but also the general population. And one of the things that we found was that in general, our patients with hairy cell have better social support than the general population of patients with chronic diseases. And, you know, obviously we have no idea why that would be, but it's interesting how great of an impact that has on quality of life. So going back to our case presentation, I don't know if anybody has any guesses about what this patient's diagnosis was. So he's CD25 positive, but is negative for a BRAF mutation. So is his diagnosis that he's a variant of classical? Is he an actual variant, or do we need to develop an entirely new diagnostic category? So, you know, we're fortunate we have so many discoveries of new molecular genetic and that suggest novel diagnostic categories, but it leads to a lot of confusion, and patients want to know exactly what they have and what this means, because we see, we're now seeing these gene usage and mutations kind of all over the place in both diseases. And we know some of these confer an inferior prognosis. And so this is very much a work in progress. And I do also think that future combination studies will likely be driven by molecular markers. So there will be sort of like basket trials in hairy cell leukemia where there is a genetic randomization. So in conclusion, we've made enormous progress in the treatment of hairy cell leukemia. Because of the pandemic, our current treatment strategies are focusing on effective non-immunosuppressive approaches until we can get our patients safely vaccinated. The advances in the understanding of the biology of the disease tell us that there are probably new diagnostic categories that need to be refined. And hopefully our international registry efforts will help us in all of these research and clinical therapy areas. So I'd like to thank my team here at University of New Mexico. This is our local research group, and then additional collaborators, especially the Hairy Cell Foundation, which has supported much of this research, as well as the SAS Foundation, and then my collaborators at OSU.
for educating us about the management of hairy cell leukemia and relapsed disease. I myself am very much interested in hairy cell leukemia and would like to ask all questions of practical importance. What is your personal preference about weekly doses or daily doses of cladribine for hairy cell leukemia?
Yeah, that's a really interesting question. I think, yeah, clinically there does not seem to be a difference. So they're both equally effective. And so oftentimes what I find is it comes down to the patient's preference, and many of the patients prefer cladribine over pentostatin because pentostatin is given once every 2 weeks for up to 6 months, so 12 doses of therapy. And the patients really love the idea of getting their treatment done right up front and not having to continue to come either to the clinic or the infusion area. So for patient preference, most of our patients do the weekly therapy, the entire duration of therapy in 1 week.
What about the difference between a subcut infusion and intravenous infusion of cladribine into personal experience?
So there was actually just recently a paper that looked at this, and likewise the subcutaneous administration appears to be clinically equivalent. And so many places, I think in Europe, they have been administering subcutaneous cladribine for a decade or more potentially without any diminishment in the efficacy. And so I think that is a very reasonable option as opposed to the patient needing an IV of some kind.
Mentioned rituximab in the upfront management. So we usually use rituximab in the relapse disease.
Mm-hmm.
So do you see a difference in the preference of management of relapse disease if you have already given rituximab upfront?
Yeah, I was not sure how much time I have, but there is a lot of data using in the relapse setting, and I think Dr. Farhad did a lot of that work at MD Anderson, Dr. Ravandi, looking at in patients with early relapses, so 2 years of initial therapy, the combination of chemotherapy plus immunotherapy is really beneficial, and patients are much more likely to have a good response, especially in that setting where they most likely have biologically aggressive disease that with an early relapse. And so I think it would be considered kind of the standard of care in patients who have an early relapse after initial perinucleoside analog therapy, but it looks like it's also emerging as a standard upfront therapy. So similar to most of our other lymphoproliferative disorders, I think that we are going to be using more chemoimmunotherapy, both upfront and post-upfront.
So the last question, is it possible for us to participate in the registry? Can we send our patients for a registry?
So not at this exact moment. I'd love to talk to you about that. So we've been working really hard to get some European regulatory approvals, and we have found that the data sharing agreements and things like that have been difficult but not insurmountable. And so we would absolutely welcome participation from any site that has hairy cell patients. And if you'd like to email me, after this talk, we can get you in contact with the Hairy Cell Leukemia Foundation and start talking about how we can help with that.
A question from one of the audience members was, which quality of life index are you using?
We're using the FACT leukemia scoring system, the FACT score. We have about 6 surveys right now. And all of them have been validated in leukemia, except for ours. a system that we're trying to validate ourselves, which is our patient concerns score, which talks about how hard was it for you to find a specialist in hairy cell. You know, what is your anxiety about having a rare disease? Do you know other patients with hairy cell? And so, and as I said, there is tremendous overlap in some of these validated scoring systems, but we're hoping that we can refine that a little bit more as we go on when we see what is concerning our patients.
Thank you very much, Professor Leslie. A question from Dr. TARIQ was, so it was a question in the beginning I couldn't ask. The question was, how would you like to differentiate CD20 positive myeloma cells from lymphoplasmatic lymphoma? CD20 positive myeloma cells for lymphoplasmatic lymphoma.
Yeah, I actually got this question and I wrote it back. So I'll say once again, in terms of morphology, these two are different, have different morphological appearances. The LPL cells, they have, although the shape of plasma cell, but their nuclear features are of a lymphocytes. They have like chromatin throughout the nuclei, while the plasma cell, they do have the characteristic clock phase nuclei. Then phenotypically, the CD20 expression in myelomas are either negative, or if they are expressed, they are at a lower level, while LPLs, they do express in a pretty much stronger way. Then we have CD19 and CD45 expression, again stronger than plasma cell myeloma. And finally, MUM1, IRF MUM1 expression is negative in LPL and is quite positive and strongly positive in cases of myeloma.
Thank you very much, sir. On behalf of Pakistan Society of Hematology, I thank you very much, Dr. TARIQ from Shaukat Khan Memorial Hospital, Lahore, Professor Leslie from University of New Mexico, and Dr. TOBY from Oxford. And I thank all the members who have attended. There are more than 70 audience members, our students and young consultants who have been benefited by your talks. Thank you very much. And I over my mic to the President of Pakistan Society of Hematology for expressing his gratitude. Thank you very much, everybody. Over to Jennifer Baser.
Thank you, Marine. I think it was a wonderful webinar and sixth in the series of CME by the PSH. And as we know, the lymphoproliferative disorder, these are one of the most challenging area in hematology, and I'm sure all the participants they had a useful. They learned a lot from these wonderful talks by the very experienced and learned speakers. And I, on behalf of PSH, express my gratitude and special thanks to all the speakers for sparing their time and giving this talk on our webinar. And thank you very much to the speakers, and thank you all the participants for taking interest and a lot of sparing out your time on the weekend. Thank you so much.
Thank you very much. Thank you very much, Leslie. It's Saturday going on, and thank you very much for sparing your precious time.
Oh, thank you. It was an honor to be here today.
We hope to have further collaboration on HeReCell.
Yes, I would love that.
Have a good day.
Thank you so much.
Thank you.